All right, hello and welcome to How to Evaluate Radiology AI Now and in the Future. We are really excited that you are joining us today and are taking the time to be with us during this discussion, during this webinar, which we will first start with two talks and then with plenty of time for the discussion and questions from you. My name is Georg Langs. I'm Chief Scientist at contextflow and Professor for Machine Learning and Medical Imaging at Medical University Vienna, and I'll be moderating today's event. And just as an intro, this is a collaboration of contextflow and Collective Mind, and I want to thank Collective Minds here also for helping to organize this event. If you're not currently a member of Collective Minds community, I would highly encourage you to join. It's a platform where you basically can post cases, get feedback, and also try out technology and what the industry is offering right now. We at contextflow are developing deep learning software for chest CTs, and we are using the Collective Mind platform for letting others try out the software and also for FDA studies, for reader studies. So cutting to the chase, we have a great group of panelists today. They are each presenting a brief presentation on their experiences when evaluating AI, when introducing it into the clinical routine, which we all know is something that's challenging and something that we would like to learn a bit more about. But then we will leave plenty of room for questions, and please use chat functionality of the Zoom in order to enter your questions. I will read all of them and we'll make sure that we answer as many of them as possible. So please, all the way during the talks, whenever you have a question, just put them into the chat. I will make sure that we will pick the questions up. Unfortunately, one of our panelists, Henriette Stahlbrand from Jönköping, has fallen ill, so she cannot join us today, but we'll make sure to invite her to one of the next webinars. So with that, let me introduce you to our first speaker today. It's Dr. Geraldine Dean, and she is a consultant radiologist with an MSK focus at Epsom and St. Heliers University Hospitals, NHS Trust, and she's the current AI lead for AI Southwest London Group for the NHS. She is also the head of UK clinical strategy on AI implementation for TMC, and she serves as an advisor to various industry organizations. So thank you, Geraldine, for joining us today. And I'm really curious and looking forward to your talk.
Thank you very much. So, can you see that okay?
Yes, we see it.
Perfect. Okay, so let's start. So thank you very much for that kind introduction, and good evening, everyone. Today I will be going over my experience on how we evaluate AI tools in the NHS, specifically with my team in Southwest London, and also at TMC, which is a teleradiology company where we have so far adopted about 17 tools and currently using 10 AI tools in our workflow. So just wanted to start off with building a strong, diverse team, which is a very first important step, not just for the whole implementation process, but also specifically to evaluate these tools. A team made up of different stakeholders with different expertise that are brought in from the word go should, in our opinion, be part of that evaluation process. So to give you an example, my knowledge in IT is limited, and my input as a doctor in that process is going to be more towards the clinical aspect of the tool, the user experience, the scientific side to it. Nonetheless, I think it is very important that each aspect of this evaluating process needs to be addressed equally. So to give you an idea, this is how our team looks like in Southwest London. We have an AI lead, we have a local champion, which is project specific. That person is very important, making sure the day-to-day running of that project is going well. There's an operations lead, a research lead, we have an integration lead, we have a member of the executive team to help us with those occasional nods that we need. We've got information governance leads, IT lead, and an education and training lead. So the next step in choosing the right product, in our experience, is building a good blueprint and having roadmaps to follow. For instance, this is one of the roadmaps we use, which is specific when in the stage of choosing a tool. We believe that to choose the right tool, there needs to be first a specific problem that needs addressing, and only by pinpointing that specific problem can you choose the right tool for your department or institution. Without a formal process, one may choose the best reputable product, or the company that has most visibility, or the company that you have the closest relationship with. However, that may not address one's specific needs, and therefore this ensures that the need of the client aligns with the intended use of the product. So the way we approach it is, first, we identify the main problems that we are facing, whether in the company, in the department, in the trust. Then we look out to see if there are any AI tools that can help with these specific problems identified. Once we target the problem and agree on an AI tool which may possibly help, then we start our market research of all relevant AI tools out there with relevant regulatory clearance. And then we get all those tools that are out there, those companies, and look into these tools in depth. And then we select the product that is right for that specific department or trust. And that's very important, because a tool may be great, but it has to be right for your own specific needs. So I just wanted to show roughly how the market is segmented currently. In the last few years, we have seen an exponential increase in the development of these tools. To date, there are more than 200 FDA and CE mark products in the imaging AI space. Therefore, evaluating large numbers of tools, whilst, most of us are doctors working in a busy environment, radiographers, business developers, we might not have the time to do it. This does take time and a lot of attention. However, it's a very important process. So to give you an idea, as I mentioned, this is how the market is segmented, where there's mostly in MRI, where there's 34% of AI tools are in MRI, 36% in CT, followed by X-ray, mammography, etc. And this to give you an idea of the products that are out there and the companies which move together as expected. We mostly see products from the neurospace, neurology at 36%, secondly to chest, moving on to breast, and MSK first, breast, etc. So how do we go about it? There's so many products. You've pinpointed the problem, you want to choose a tool. So in order to help this process, my team in Southwest London have put together our own point scoring system. I know the words here are small, and you don't need to try and read this, but I just want to give you an idea of what our document looks like. Essentially, this is a document that guides us, and we use this score sheet as a guide. We score it out of 24 points, and if someone does not have any expertise, and this is an important point, in any of these categories, for example, myself, when it comes to IT, then I just leave that score blank, not to negatively influence the result. And then we look at these scores for each subsection individually. The real aim here is to try and make this as objective as possible, which is not easy to do, and to also, very importantly, ensure that all areas are addressed before taking conversation forward with any companies. We would do this for every product available that may address that issue or problem that we are trying to address. So what we are looking for is, I tend to classify them into hard and soft criteria. So for me, the hard criteria, the objective criteria that are based on functions and elements that are crucial for the success of this implementation. And then there are the soft criteria, which are more elements of a product that cannot quite be quantified, and represents, however, aspects of the product which are felt still very much important for this process. So just to give you an idea of the hard criteria, there's in general, what disease is being targeted, what the intended use of the tool is, what is the market presence of that tool and company, which continents are they in, which countries are present, are they more involved in clinical, more in research, who are their clients, is it more research institutes, paying institutes, the number of products they have. We look at the evidence, any study results. We look carefully at the author list. Is it vendor independent? We look at any validation studies, what sort of post-market surveillance they're doing. Pricing, very important. Sometimes pricing starts being discussed at a later stage, and we always encourage pricing to start being discussed at a very early stage. Data characteristics, the technology, very important, regulation. And then the more soft criteria, for example, the reputation of a company, the reputation of a product. For example, myself being in the UK, is this product taking traction in the UK? Is there any local use? Anyone I can speak to has been using it? Is this product original? Are there any direct competitors? Is there a significant edge to this product? And very important, the ease of use. Does it integrate easily in the everyday workflow? Myself as a radiologist, am I going to be fine using it? Is it going to help me? Is it going to irritate me? So these are all different aspects that we look at. We know that there are many challenges in the whole implementation process, and there are some specific challenges when it comes to choosing the product in terms of specific to the product itself. And one of it I find is lack of transparency sometimes from the vendors. As I mentioned, sometimes it's with pricing. It takes 3 to 4 meetings sometimes to get there. Sometimes it's probably easier to bring that conversation earlier. The intended use of the product, regulation. It sometimes is difficult without speaking to the company to see exactly where they are in that regulatory process. And also evidence. We know there's a general lack of evidence, which is understandable to a point, but also sometimes it is difficult to find that evidence that's linked to a specific product. So this process does take time. I just wanted to briefly go over not just evaluating a tool in order to introduce it into the implementation process, but I wanted to focus a bit on safe implementation of AI, because without monitoring the tools and without constantly trying to evaluate the tool, making sure that it's performing well, then that is such a crucial aspect in that process. So we can't just choose the tool and then just let it be. We have to constantly keep an eye on it to make sure that it's still adding value to our department or institution. So for that safe implementation of AI, we know that first we have to address a specific problem, but that impact can only be realized if the implementation process is safe, because we know that when deploying these AI tools, risks can surface. So I'm sure most of you know about certain risks that come with implementing these tools. However, I will highlight them again just to emphasize the importance of surveillance and how we should not stop trying to evaluate these tools and not just leave it for that initial phase. We know that there's bias and quality. The training data sometimes may not be accurate. It may be biased and not representative of the population that's being served. There's human AI interaction, which is very important, where there may be limited human AI collaboration, which may lead to the ineffective use of the tool. Another important risk is adverse events, of course, incorrect or misleading outputs, which may happen, which can sometimes lead to harm. We need to keep an eye on performance degradation, where we know that this may occur over time with new cases as the technology evolves. Very important is generalizability. As we mentioned, tools may perform differently on different cases with limitation or bias in real-world scenarios. and regulatory compliance, where data protection and quality assurance requirements will be needed. So what do we need to focus on after choosing that perfect tool? It's important that we need to be gatekeepers of the AI tool outputs. It's important for us to build a framework for supporting the use of AI tools that specifically focus on ensuring acceptable local performance. So just to summarize, we highlighted the importance of building a strong team initially with different expertise, importance of involving all stakeholders right from the beginning. Choosing a product takes time, but it is a very important step. The tool needs to be assessed from all angles in order to find the best fit for you. And these tools also need to continue to be monitored. This is my email address. Feel free to get in touch, and I look forward to any questions.
Great. Thanks a lot, Geraldine, for this talk. We'll keep the questions for after Jakob's talk. So please, again, a reminder to everybody, please put your questions into the chat so that we have a great discussion afterwards. And with that, I'd like to introduce our second speaker. Thanks for joining. Our second presenter is Dr. Jakob Visser. He's Chief Medical Information Officer and an Assistant Professor of Value-Based Imaging at Erasmus Medical Center in Rotterdam. He's also the Chairman of the Scientific Committee of the European Society of Medical Imaging Informatics. And so he's someone, I think, who is incredibly familiar with the challenges that we are discussing here and with how the state of AI in radiology advances, but on how also the challenges of actually implementing it and bringing it onto the road in clinical healthcare are there and are developing. So I'm really looking forward to your talk, Jakob. And
yeah, thank you for your brief and your kind introduction. I'll try to share my screen now. Hopefully it works.
Yes, we see it. Perfect.
All right. So thank you. It's my pleasure to give this presentation, and I appreciate the invitation very much. These are my disclosures. And I think it's very important when talking about artificial intelligence, AI in radiology, that we really consider the added value, right? So basically it's all about added value. That's also something that the vendors do realize. And what we basically see here is that there is two big groups in terms of value. So we have the one group that's about the quality. We see that approximately 2/3 of all the claims of the vendors cover better quality, and the remaining 1/3 is about efficiency. So that's the claim of the AI vendors when talking about value of AI in radiology. And if we think about quality, what do we think about? So we first can think about, of course, models that can detect abnormalities and diseases that radiologists may overlook. The other application could be that there is a phenotype of a tumor that can be determined using radiomics to better target a specific therapy. Other application could be to identify a population at risk that has particular findings like coronary disease, emphysema, osteoporosis, for example. And of course, it could also be the second pair of eyes, just to name a few applications of quality. If you talk about efficiency, we could think about AI that can automatically alert clinical care teams for, to get them into running for stroke patients or patients with pulmonary embolism or other emergency conditions. Also, performing complex measurements like the volume of a nodule, for example, that all can be be done in an efficient way by an AI algorithm. So it's either quality or efficiency that can be reached by applying AI in radiology. But it's important to to think and to keep in mind that the added value of an AI radiology application depends on the context. So for example, a specific AI application could have added value in Africa or in Nigeria, India for TB, for example, but of course it doesn't matter in a European situation. Or if you treat cancer patients, that's a fully different population compared to, for example, MSK patients. So it's also dependent on the workload. So the value of a radiology AI tool depends on the context. So that also perfectly matches with the words of Geraldine that she just mentioned. It's about a problem, the local problem, what can be addressed in a local situation with a specific radiology AI model. And then we come to evidence, right? Because we have to realize that there is a lot of AI algorithms available, but most deep learning algorithms show a fall in accuracy in external data sets. And the lack of diverse data sets in AI research puts patients at risk, right? So there is only a limited amount of external validated algorithms that really show the performance of an AI algorithm. So it's when you develop an AI algorithm, it shouldn't be only internally validated, but there is also a need for external validation. And that's highlighted in this publication only 1 year ago. We see that among a lot of algorithms, only 6% has been externally validated. And then, of course, you would say, is that really a problem? And it is, because one of the graphs in this particular paper showed that a lot of the algorithms showed a fall in external accuracy, meaning that that are the dots on the left side of the vertical lane, right? So it's important to make sure that also in an external population, the algorithm works well. And here we see again that nearly half of studies performed show at least a modest decrease in external performance. And it's important to realize that talking about value of radiology, it's not only about accuracy. Of course, we need a good accuracy of the model, but it would be good to apply the so-called hierarchical model of Freiberg that has been published in 1991. And he basically says, if you want to be effective in a diagnostic test, so it's about diagnostic tests, but we also can apply that to AI in radiology, AI algorithms. Of course, it needs to work, right? So there needs to be technical efficacy. If it works, then we need to show diagnostic accuracy. So high sensitivity, specificity is needed. If that's in place, we have to consider what's the impact on the diagnostic thinking, what's the impact on the diagnosis. Then the fourth level is, how does it affect the therapeutic decisions? And if it affects the therapeutic decisions, of course, it's important to realize what is the patient outcome that is being affected by application of the AI algorithm. And of course, the sixth, the highest level, we need to show cost effectiveness, right? So it's all about the money. Effectiveness is nice, but what are the costs to reach that particular effectiveness, right? So at least we need to show from the third level that there is an impact of AI algorithms on patient care. And then the problem is, this is 2 years ago, but it still holds that a lot of the evidence is at the level 2, still at the level 2. So there is limited evidence, that also been mentioned by Dr. Dean, the Geraldine Dean. There is limited evidence available of applying AI algorithms in daily clinical practice. So we really need to reach the higher levels of evidence to show that there is an added value for applying these algorithms. And if you think about generating evidence, it's also important to realize that it's not just doing some retrospective study, right? We need to do appropriate and well-designed studies. Ideally, it should be randomized controlled trials. I'm not saying that we always need randomized controlled trials, but we need really think about building proper studies using the right designs in order to get to the answer for the effectiveness of a particular algorithm, right? And there is only limited evidence available. It also has been highlighted in a recent editorial at the beginning of this year. The RCT remains the most powerful type of study. Again, it's not always needed, it's not always possible, but it's at least important to consider performing such a study design. And talking about implementation, it's not only about the effectiveness. We also have to consider costs, and costs for the AI model, for the algorithm, but also, of course, for the infrastructure. Is there any hardware needed? The cost for the implementation, for the management of all the stuff. And please do not forget, there can be an extra treatment because of an increased detection of, for example, pulmonary embolisms. So recently we had a publication that showed that the detection of pulmonary embolisms, incidental pulmonary embolisms, was doubled. So that means also that the treatment doubles, right? So what's the effect, what's the impact of the extra detection? And of course, we also have to consider the carbon footprint, because running an algorithm means also some carbon footprint. And here we see, that there we have to balance, right? So there's patient outcomes, there is impact, there is effectiveness, but there is also costs. And we have to weigh those, the two of them, in order to make the right decision if it's worth the effort to implement that particular algorithm. And there's different methods to do that, but it starts with a good estimation of the effect of the outcome, and then compare it and see if it holds against the costs that are being made. Another thing to consider is stakeholders, right? So there is different perspectives. Of course, we can have a look at it from a radiology point of view. I would like to call that the micro level, the department level. So for example, can we report faster, right? It's important, but that's on the department level. But we also should consider, what's the impact of AI on the care pathway level? Can turnaround times be accelerated, not only for the radiology department, but for the care pathway in total? And what's the effect of additional detection of pulmonary embolisms? And of course, we also need appropriate study designs to cover that. And then we have the macro level, the societal level. Is the number of fractures decreasing, for example, when applying a particular algorithm? What's the cost effectiveness from a society perspective? And then another important thing when thinking about evaluation of AI, monitoring of an algorithm. Part of the AI ecosystem is the ongoing monitoring performance. Here is another example. Monitoring is important. It is also being addressed last week in a WHO report of AI about AI. We need continuous ongoing monitor performance. And why is that? That's because they deal with the so-called model drift. So the accuracy of machine learning models degrades over time. That has been showed also here. When the model was built for patient waiting times, at 14% point decrease when using old data versus new data. And also another very, very nice publication by Dr. Langs a couple of years ago, showing that the model performance decreases over time. So we really need to keep track of the performance of algorithms of AI models. And ideally, of course, you are in the position to give feedback. So you monitor the AI, you reject or accept the AI results, so that the algorithm can be fed with new input to improve, basically, and to keep the right level, the same level of the AI performance. So to conclude, the value proposition differs it's dependent on the context, it's dependent on the stakeholders. More scientific evidence is needed. We need to involve the stakeholders to get a full perspective, and the monitoring algorithm performance is required. And that's it for now. Happy to answer your questions. Thank you.
Thanks a lot, Jakob. That was a fantastic lecture. Thanks to both of you. I'll start with a few questions. We're already getting some in the chat, but I'd like to again encourage everybody to put your questions into the chat. I'll start with two questions that came to my mind while I was listening. And one was, first for Geraldine, you described the team that you need or that you kind of can use in order to implement AI in the clinic, in order to judge what is good, what is not so good. And I think many are asking how to build up such a team. Do you draw that from the radiologists that are in the department? Do you connect to the IT? Does it mean that you have to basically build up a new team from scratch with hiring people? How do you compose it? How do you go from not doing that to kind of having a team to help you implement AI in the clinic?
A great question, because it's not an easy task, actually. You can find yourself in an environment where an AI team already exists, okay, and then you can improve on that by building on it, and that's going to be easier. But in most cases, since all this is relatively new, you may have to start it from scratch. And when in my personal experience, when I started it, I'm going to talk about the NHS, the public sector, because that's the trickier bit to build that team. In the private sector, say at TMC, it's easier in that respect. In the public sector, in NHS, the way I went about it is, first of all, get the nod from the people from above. I actually, you got to pitch it to the executive team, and once they're happy with that, you're going to get support. Now that support is going to lead to more people possibly being interested. Now the tendency is that whoever's leading that team, so for example, I am the radiologist, and obviously I have more connections with radiologists, right? But it's very important that that team is built by people with different skills. So one has to go out there and convince that one IT person in a world where they're swamped with work to engage and to actively engage from the beginning. Definitely someone, an integration lead, such as a PACS manager, for example. People in research. Usually I finding people in research, it's a bit easier because it's such an interesting field. So for me, that was less of a challenge, but definitely the integration people, the IT people, governance leads, they're very helpful, but they're busy as well. So it's a case of networking, selling your case, convincing people and bringing them on board and starting off like that. And then it will look different in every different institution, what your needs are going to be. But you can adjust that as you go along. But one role that can be overlooked, because it's easy for it to be overlooked, is education and training. You can go ahead and implement without having an education and training lead, but it would be so much better with that education and training lead, because you will find yourself so busy that you may overlook it.
Great, thanks a lot. Jakob, I have one question for you. And you talked about added values and stakeholders, and also about the context in which the value can really be kind of gained from these tools. And I think, like, we know that there's the accuracy measures and the quality measures, but then I think you also mentioned these downstream measures on kind of physicians that actually use the radiology outcome or reports. Can you tell a bit about where your feeling is where we are now with the relevance of efficiency versus quality versus kind of more downstream benefits of AI in terms of being really relevant for decisions to take it? And do you see something developing here, maybe towards more kind of sophisticated outcome measures where the impact of these softwares are evaluated?
Yeah, so thank you for the question. Regarding you see, as I also showed during the presentation, a lot of research is still focusing on accuracy, right? Showing sensitivity, specificity. You see an increase, but now, you know, also the AI vendors, they realize that it's sensitivity, specificity that doesn't sell, right? So you need to show either quality or efficiency. So there is some studies showing efficiency for radiology, right? But that it's not up so far. It hasn't been convincing, at least to those who should pay for the AI in radiology. What you see is that there is an increasing interest of other departments than radiology in increasing efficiency in terms of, for example, lower the time that the patient is at the emergency room, right? So, for example, right this morning we were discussing in a debate with the emergency room, how could we lower the time that the patient is in the emergency room, and how could it be affected by the usage of AI? And then, of course, depending on the consequences of AI, you could think of applying it, for example, for pulmonary embolism cases, because those tools that are currently available, they have acceptable sensitivity and specificity. So you could think, okay, let's do the first reading by the AI and then make the decision based on that particular output. And then the second read is done by the radiologist. And of course, it may cost, you know, some patients need to come back to the hospital, but that's the way of thinking that you see. And then, but then you are talking about efficiency, but for the quality, you see an increased tendency of the well-designed studies. So also the example I just mentioned, it's about X-rays, chest X-rays, and the randomized controlled trial in the United Kingdom that sponsored by the NHS, that basically investigates how does the AI affect the turnaround time or the diagnosis to lung cancer. So you see that the research is moving towards more clinically relevant KPIs, and those clinical relevant KPIs are not limited to the radiology ones. So it would also help to build a business case together with our referring physicians to basically make it happen that the adoption will increase.
Great. Thanks a lot. There are two questions that I think are touching similar topics for Geraldine, and one is about how to monitor and evaluate the user satisfaction and the acceptance of the tools when you introduce them and as they kind of are used a long time. And I think a link question is also how to share that across institutions. How can you basically learn from other institutions about the utility and kind of the ease with which these tools fit into the workflows of radiologists?
Thank you for that. So first of all, what we do is, to start with the first part of your question, is we do a pre, during, and post-implementation survey. It's a long survey, but you know, you'd be surprised, we get quite a bit of engagement, so that we find that quite useful. And one thing I've learned is that the actual tool people are usually dissatisfied, not by the tool, but the tool usually brings with it some sort of change in the system, change in the flow of something. So to give you an example, we brought in a chest X-ray AI tool to implement a same-day CT scan for people with lung mass. So the dissatisfaction, and by dissatisfaction I mean it created some work until we got it going, was suddenly we're offering a CT, so we had to open up CT scanners for those patients. So what I've learned is that these AI, it's not just about the AI tool, but what it means to when you bring in that tool, what's going to change. And that's why it's good to have these surveys to keep an eye on that, because you can be so focused on one aspect. Now, monitoring is very important. It's something I feel strongly about. My worry, it's not a worry, it's not my concern, is that especially at the moment, say we've got this grant coming that came out for the NHS, a lot of teams applied for it, that there's a lot of hype to introduce the tool, but then what happens next? You know, because it's easy to just leave the tool in the background and just let it do its thing. And I worry about that. So it's very important to start looking at monitoring tools. It's very important to start not only looking at tools, the tools such as chest X-ray, CT chest, that's great, but also looking at tools to help us humans to monitor, because the monitoring process itself takes a long time. Now, sharing this data, I'm seeing the question. That's a really important point, and it's definitely something that needs to be addressed, because it's very important that we share this knowledge, that it's not all happening in silos.
Great, thanks a lot. There is a question about the evaluation of AI models and kind of how we cope with the speed with which new technology is introduced versus kind of the time it takes to do a real kind of random controlled trial to evaluate the benefit. And so, Jakob, I would like to know a bit about your view on that kind of dilemma between very rapidly advancing technology and the need to do an RCT, when an RCT might take, let's say, 2 years if you really look at an outcome measure. Is there something in between? Is there something we can do?
Yeah, that's a very relevant question, and a question I often get that one. And you know, being an epidemiologist and being a value guy, I've always you know, stressed the fact that we need robust evidence. But people already told me 2-3 years ago, you know, this is very new technique. We really need to implement it, and you know, it will be beneficial. I say, okay, but you read well-designed studies, right? And now we 2-3 years later, and there is still not a wide adoption. So I think we really do need well-designed studies in order to prove the added value of AI. That doesn't mean that you cannot use them. But if an AI vendor tells me, okay, do you want to have our product? You know, we have a very good sensitivity, specificity, it's great. I said, okay, that's fine. Then he asked me, would you like to pay? I said, of course, but what's your added value? Then I can also say and know what I have to pay. Yeah, we are not sure and we have to see. And then I say, okay, let's do research together to show the added value. If it's there, you know, we have a deal, right? So I think also for the AI vendor, it's important to come up with well-designed studies in order to convince the boards, the radiologists, scientific communities to use the specific AI tool. So, and is there something in between? Yes, I think so. So there is in silico trials. So there is sophisticated and also state-of-the-art study designs then that basically can do some artificial trials that can bring you very close to a classic RCT. So yes.
Great. Thanks a lot. And I believe that we will see a lot of advance in how to design these trials, right? And how to do them right to get that benefit out of them. Thanks. Geraldine, I think that one question is for you, because it's also about the NHS, and it is about how institutions can use tools that are not yet cleared for clinical use by the regulatory authorities. So is that possible in your experience? Does that need an agreement with the company? Do you have any experience with that?
I don't know if Jakob can add to this, because I'm not in the research world. I'm more in the real world implementation world. Because I'd like to say that as far as I know, when it comes to research, you are allowed, but I might be wrong. What I do know for sure, that in the real world, if you look at my 24-point score system, if there's no regulatory clearance, it's an automatic -24. So so that's for real world implementation. From a research perspective, I think it's a yes, but I don't know if anyone wants to say a definite yes to support that.
Yes, I can confirm it's a yes. Of course, you have the internal procedures that you have to adhere to. But if you are aligned with that and you get the approval of the IRB and so on, then you are allowed to use it in the research setting. So you cannot do that endless. Of course, there needs to be a defined period. There are specific conditions you have to meet. But yeah, you can use it.
Great, thanks. I have one question. There was one question about, and Jakob, that I'll put it to you. Thoughts about overcoming resistance. And I think there is the level of management and higher level kind of executives at institutions, but there is also the people who actually have to use the software, or have to kind of maybe even change their workflows because of the software. Any experience with that? How to approach that? How to make it beneficial or kind of workable for people who are not convinced initially?
Yeah, I think that is a very important topic, and 200 ESD students are also doing research on that particular topic. You know, how to increase the acceptance of digital technology in general, but also how to make sure that radiologists do accept new tools like AI. I think it's important. Several items I would like to address. The one that has also been addressed by Geraldine. You know, if you start from the problem, right? It shouldn't be a technology push, but if you ask them, you know, what you need, how could we help you? How could we assist you? That helps in the assistance. That's one thing. Then the other thing is we also had a recent implementation of AI that kind of was separated from the current workflow. I think the seamless integration into the workflow, that's crucial, and that also will increase acceptance. And then the third thing is people need to get trust in the algorithm, right? So I think we could say no algorithm is perfect. So there is sensitivity, there is specificity. I think you could see that there will be a relation between AI, the algorithm, and the radiologist. And in a relationship, you have to know to what extent could you trust each other, right? And in relation to the algorithm, there is sensitivity, there is specificity, there is false positive, there is false negatives. So you should know what are the particular areas where the algorithm shows false negatives and false positives, right? So to gain trust in the algorithm, I think that's crucial. So starting with the problem, seamless integration into the workflow, and gaining trust into the algorithm. I think that helps the acceptance of the radiologists.
Great, thanks. Geraldine, I'd like to ask you that, and I think it's a really important question that many of us are thinking about right now. It might sound a bit technical, but it's really, I think, shaping a lot what is happening in the industry and in the adoption. But I think a lot of people are looking about where the decision goes. And the question is, where do you see this relationship or the maybe the competition of marketplaces and PACS vendors going? What will be the kind of end state that we are moving towards, or doesn't it really matter, because in the end, in this aspect, they are so similar that it will be just different providers? Any thoughts on that?
$1 million question. Who's going to win the war? I can tell you where I would like to see it as a radiologist. I as a radiologist, I want to be able to work with not having, and as the AI lead, to bring in an AI tool separately from different vendors and going through the hassle of that, because it's a big hassle. You know, for us in the NHS to get a DPIA is minimum 4 months is like, wow, that was amazing. You know, it can go on up to a year. So I suspect that it will move towards, for example, PACS. I think that would work well, that you're using your PACS and within it, you've got your AI tools, which you can pick from. How that links with marketplaces, I'm not sure. But what I do know is that doing it individually, tool per tool, between different companies as a radiologist, I think that's not easy to implement. So I'm hoping that yes, we'll be in a situation where you can just go into PACS or RIS or marketplace and pick your tool and use that.
And maybe as a brief follow-up question, do you think it matters to which extent that the user experience is similar? Like, is there a certain willingness to work with many different ways to interact with software, or would be the optimal part more towards going to one interface and you don't even realize what kind of algorithms are running below the surface? Or is
I'd like to tell you the latter, because for us as radiologists, we just want to get on with our work, right? We just want to go through one case after the other. But in that process, it's very important that radiologists understand the AI they're working with. So it's important that we know why the AI is producing those outputs. It's important that we don't rely on it too much. So in the ideal world, yes, hidden just works seamlessly. However, we've got to be aware that we also need to be conscious of the fact that radiologists need to keep reminding themselves that they are working with an AI. They need to keep questioning those outputs. They need to make sure that these are going to be monitored, and just keep an eye on it. So hidden, but keeping an eye on it.
Thanks. Great. Jakob, one question, and I think it's a surprising question because I did not yet think about it. When we think about strategies about implementing AI and bringing AI to the clinic, should we at the same time also define criteria or having a plan for decommissioning software? What's the criteria basically to stop using it?
Yeah, so we recently talked about the AI lifecycle in the RSNA, and it was also mentioned there. Starting with AI means monitoring with AI. That means that there is the potential to stop, right? So monitoring means that you keep track of the accuracy of the algorithm, but you also need to be aware that there needs to be an ongoing business case, right? So for example, if you have an AI tool for prioritization, and now the backlog is not there anymore, you know, you could think, okay, is this still a use case, a business case, a positive business case in my particular situation? Or if workflows changed, you know, that also could change the business case for AI. So monitoring, in my view, means not only keeping track of the accuracy, but also think not daily, but at least annually, think about the business case. Does it really matter? Does it still matter to use this algorithm.
Great, thanks. Thank you. Geraldine, one question to you. You mentioned in your talk that you are working with different hospitals, and like one big part is of that work is understanding what they really need. And also, Jakob, you mentioned kind of the context dependence. And so I'm really curious about, in your experience, how much do these needs differ? Are there kind of common threads that go through all of the hospitals? Where do they differ, in which aspects of their needs?
So I presume by needs you mean the problem we're trying to address and
Yes.
why we're introducing that AI tool. So again, I'm speaking as a radiologist. The general overarching needs are going to be similar, okay, across the board. And, you know, we all want more efficiency, we all want more accuracy, but then specifically within different institutions, you may think, okay, we've got a problem with our lung cancer pathway, but actually our stroke pathway works pretty well somehow. You can go to a different institution and say, actually, it's our stroke pathway that's really struggling. So it's in that respect. So that the institution that's struggling with the stroke pathway shouldn't be focusing on the chest x-ray if it's all okay in that department, because there's most visibility with chest x-rays. And that's what but I think the problems we are facing, the overarching problems, are similar, but then there are going to be specific needs within different institutions, within different teams that need addressing. And those different needs need to be accounted for when you're looking at which product to choose, because every different products offer different angles and different types of solutions.
Great, thanks. Well, thanks a lot, Geraldine. Thanks a lot, Jakob. We are at the end of the hour. Thanks a lot, everybody, for participating. I'd like to close with one more personal question that one of the participants asked about the motivation, but I'd like to pose it to both of you. Maybe first Geraldine and then Jakob. What was your motivation to getting into this field of trying to figure out how to bring this software to the clinic?
Shall I go first?
Yes.
My motivation is mainly because I do think that AI will change our role as radiologists. I don't think that AI is going to take over at all, but it will shift our role, and it will shift our role in a way where we need to become leaders in this field in our own right. So it's up to us to have that motivation to take a leading role, because if we don't do that, it will happen that AI tools will land on our desks and we need to work with them. But we need to keep an eye and be the gateway to that. We need to start collaborating with teams that we never collaborated before with, engineers, data scientists, right from the beginning of our training from medical school. That's not something we're used to doing. Speaking the language, there's going to be a language barrier. The tech language is very different from the medical language. So I think it's mainly because I felt responsible, not just, you know, I think to take that leading role, like I think all our radiology colleagues should, in a way.
Thanks a lot. Great answer. Jakob.
Yeah, so for me, it's I really believe in the added value of AI. It's innovative, it's a great potential, but it needs to be implemented in a responsible way, based on good scientific evidence. And we also need to keep track of the costs, right? So there needs to be cost-effective implementation based on well-designed studies. And, you know, I feel responsible for that. And that's very important to me. And the second point is, from a global point of view, I think that AI can help in decreasing health inequality. So, for example, people in Nigeria, they didn't have access to X-rays and reading those X-rays for TV screening. So AI can help in decreasing the health inequality and basically therefore increase the people's health across the world.
Thanks a lot. Thanks a lot, Geraldine. Thanks a lot, Jakob. I think there were a couple of questions. I think many questions that also came to my mind now during the discussion, but I really enjoyed it. I learned a lot. Thanks everybody for joining. Thanks to the two of you for taking the time and sharing your experience and knowledge with all of us. So thank you. And I hope we see each other in other webinars or in other conferences. And I'm really looking forward to that. And thank you to everybody. Thanks again to Collective Minds for organizing this webinar. And I think some of you, at least we and Collective Minds, will be at RSNA. So if you want to come, just drop by. But for now, thank you and have a nice evening. And thanks for joining and taking the time. Thanks.